Okay, good afternoon, everyone, and welcome to this our 52nd MRF HIV STI Echo. I am Dr. Gregory Boyce. Welcome. Again, we very much are grateful for giving us a little piece of your time, energy, and hopefully a piece of your wisdom today. Today's session, the didactic presentation, is going to be done by Ms. Belinda White, who is our clinical psychologist, and is going to follow up on a presentation given earlier on personality disorders. It's one of the sessions, one of the topics that we are, I think, don't quite fully understand, at least I'm speaking for myself. So I learn a lot from these sessions. That gives me greater insight when I'm seeing a patient who would generally think of as difficult or oppositional or hard to deal with, what I might actually be looking at and how I can better meet their needs. A quick housekeeping note, sorry, I spoke incorrectly, it's a 53rd session, sorry. And we're going to have two brief polls today. One at the end of the Belinda's didactic session, just to give us an idea of how we feel about how the presentation went. And then at the end of the case presentation, close to the end of the session, we're going to have another poll about, just to get some feedback from our community as to how we're doing with respect to the level and the length and the topics and the presenters and that sort of thing. So again, thank you very much. And I'll turn it over to Ms. White. Let's just wrestle with technology a little bit and hope it doesn't wrestle back. Here we go. All
right. Good?
Yes.
All right, good afternoon, everyone. As Dr. Boyce mentioned, we'll be covering personality disorders once more. I presented this, I believe in June. It was around June 10th. And so this is going to be the second installation of personality disorders. Next. That's all right. Okay, so the learning objectives for today would be, of course, to revisit the definition of personality disorders according to the DSM-5, discuss research on the prevalence of personality disorders in the Caribbean, tools used to assess and identify personality disorders, and finally to discuss a commonly encountered personality disorder and the most appropriate treatment. So of course we're going to need a refresher because it's been more than 2 months by now since I presented the first installation of this. I didn't think it would be fair for me to just continue without looking back briefly. So again, we're going to quickly run through what is a personality disorder according to the DSM-5. It is a persistent pattern of internal experiences and behaviors that differ significantly from the expectations of an individual's culture. Now, this persistent pattern of internal experience and behavior can be identified as pervasive, inflexible, consistent over time, causing distress or impairment, and it has its onset in adolescence or early adulthood. Next. So, a bit more on what personality disorders are. An individual's personality is influenced by life experiences, their environment, meaning their home environment, school environment, the culture that they belong to, as well as inherited characteristics, which could refer to an individual being predisposed to having a mental health challenge or illness due to a family member also having a mental illness. So let's say an individual's parents has a mental illness, which could range from substance use disorder to depression to an actual personality disorder, then their offspring is more likely to also have a mental illness because of that predisposition. Next, personality disorders may affect at least 2 of the following areas of an individual's life. So it affects the way they think about themselves and others, the way they respond emotionally, the way of relating to other people, and finally, the way they control their behavior. All right, so now we got to the interesting part. I found it necessary to make personality disorders relatable to us here in the Caribbean. And I did some research. Unfortunately, there aren't a lot of studies that were conducted in the Caribbean that talks about prevalence of personality disorders. However, I did come across a study that was conducted in Jamaica and published in 2013. And it particularly looked at the patients on the psychiatric ward and the substance abuse wards. And it found that out of the entire sample size of 100 persons, between 51% and 86% were identified as having a personality disorder. Now, this is a huge range, right? 51 to 86% is a huge range. But the reason for this is there were several tools that were used during this study, and we'll discuss those tools in a bit. But the reason for this being really relevant and important is because it highlights to us how often we may come across a personality disorder within a primary healthcare setting, which is a setting that many of us are familiar with or may currently be working in. And so it's important for us to pay attention to that. So as I feel like I'm repeating myself, go back. So the last bullet point there just says that more than half of the patients seeking treatment for mental illnesses and substance use also had comorbid personality disorders. And this is super interesting to me because more than half is a lot, yeah? And we have to pay attention to that. Next slide. So, as I mentioned, there were 3 tools that were used in this study. And the goal of this study was really to test the Jamaica Personality Disorder Inventory against the gold standard of the study, which is the clinical interview, to see how accurate it may be. And the findings of the study reflect that the GPDI was, the results of it was much more close to the results of the clinical interviews conducted, whereas the IPDES it found it identified more patients as being having a personality disorder, which means that it may not be too valid, right? So it was sort of identifying so the scale accounts for the higher range of the percentage, as I mentioned before, which is about 86%. That is accounted for by the IPDE. Whereas the Jamaica Personality Disorder Inventory and the clinical interviews, which was the gold standard, they accounted for the lower end of the general population that was screened. So I'm just going to briefly explain what each of these tools are. So the JPDI is a 38-item interviewer-administered questionnaire. And the purpose of it is to identify the probability of being diagnosed with a personality disorder, right? Then we have the International Personality Disorder Examination Screening Questionnaire, quite a long name, which is a 77-item self-report instrument that detects the presence or absence of a personality disorder. So we identify different types of tools, right? We have the interviewer administrated, and then we also have the self-report tool. Then finally, we have clinical interviews, which as I mentioned, was a gold standard used in this study. And the clinical interviews are basically a one-on-one interview that is conducted by a clinician, clinical psychologist, psychiatrist, with the patient, and it covers numerous aspects of the individual's life in conjunction with the Diagnostic and Statistical Manual. At the time of this study being conducted, they would have been using version 4 of the DSM, and now we're on to the version 5. However, the clinical interview is still very applicable, and the DSM is, of course, a very relevant tool to use in identifying any mental illness, right? So the conclusion of this study was that all psychiatric and substance abuse populations should be screened for personality disorders as part of a standard assessment procedure, which again, I found interesting because I wondered if this is being done, in our primary healthcare settings, when persons come in for a psychiatric challenge or a substance use challenge, are we screening them for personality disorders? Next slide. So, general tools to use for personality disorders, as I mentioned, we have a clinical interview, a structured interview. Then we have a self-rated questionnaire. For example, the personality diagnostic questionnaire, there have been studies conducted on this particular tool, which talks about its suitability for a primary healthcare setting. And it wasn't found to be very suitable, but I just mentioned it here because it exists and it fits the category of a self-rated questionnaire, right? And the next is the Minnesota Multiphasic Personality Inventory, MMPI. So self-rated basically means you give the tool to the clients, whether it be online or so the MMPI could be done on a computer. You can actually give them a tangible paper for them to use. It's like a questionnaire, so they go through it and they select whichever items is most relevant to them. And then the interviewer or the clinician will take it back and score it, etc. So we have structured interview, self-rated questionnaire. Next is projective test, right? Which, for example, is a thematic apperception test. And finally, as I mentioned, the diagnostic and statistical manual on mental disorders. So I wanted to give you some insight on each of these. The first one I want to do is thematic apperception tests, but I want to throw it out there to find out if anyone has heard of this before and if they could tell me what they know. And I'll start with you, Dr. Boyce.
So I've heard it too, but I don't really, because I remember apperception was interesting. We kind of stuck in my head, so I've heard that too, but I don't really just tested too.
All right.
This is probably like 1997 during my psychiatry.
Oh gosh. Oh gosh. Let's not show years around. Anyone else? Has anyone heard of the thematic apperception test before, or any projective test really that could be used for personality disorders? Feel free to put it in the chat and let us know. If not, I'm going to share it with you anyway, so it's fine. Feel like we should have some game show music. All right, so I'm not seeing any entries into the chat, so I'm gonna, oh, there's one that just popped up. Oh no, hi Mercedes. So no, I will take that as a no, that no one has heard of it. Mercedes is saying no. All right, so a thematic apperception test is basically a projective test, which I have there as well. And the participants really, during the use of the test, they reveal their attitudes, feelings, conflicts, personality characteristics in an oral or written story that they make up about a series of ambiguous black and white pictures. So imagine that you and I are sitting in a room and I present you with a picture, a black and white picture, but you can't really make anything of it. It's a figure. It's not necessarily an animal, a thing, a person, anything like that. And I ask you to tell me a story about it or write a story about it. And the criteria is, you must have a beginning, a middle, and an end to your story. And after you tell me the story or write it down, we discuss it. Now, it's important to know that systematic coding schemes, which of course have demonstrated reliability and validity, are used to assess aspects of personality functioning, which are derived from the thematic apperception test, right? So there's a guide that you use to identify the different themes that come up, yeah? There are other projective tests that are done. I remember when I was doing my master's, we did the HTP test, which is a house tree person test. And you had to draw a house, a tree, and a person. And based on that, you use the screening guide, the scoring guide, which will indicate to you different personality traits, characteristics. And it was very interesting, right? It's very interesting. It gives you great insight into an individual's mind. And it's the reason why it's interesting is because you're not directly asking the person, so how do you feel about conflict? Right? But you're gathering it from something that they are doing and possibly enjoying, right? And you use it sometimes with persons who have literacy skills. So, of course, with a questionnaire, like a self-rated questionnaire, the MMPI, it is quite extensive and it calls for literacy skills. If you have a client who is impaired and they're unable to engage in that type of testing, then you can rely on your projective tests. So, for example, in one of my internships, I had a client, she was my very first schizophrenic client, but she was also diagnosed with an intellectual disability. And so she was not able to do literary things. And so I did a lot of projective tests with her so that I was able to understand what her experience was like. And so it's important that we highlight that someone's lack of literary skills does not exempt them from having a personality disorder. And so we have to have tools to use for persons regardless of where they are at with their literary skills or their ability to utilize a particular tool or not. Yeah, so we have options. So next slide is a detailed look at clinical interview. So I mentioned the clinical interview is conducted by a clinician with the client one-on-one. And these are some areas that are covered in clinical interview. So the client's childhood, school and occupational history, past and present interpersonal relationships. And within this conversation, you find that a lot of high-risk behaviors could be identified. So you may find that impulsivity comes up, or an individual's drug use history comes up, sexual history comes up. All of those things are very relevant and pertinent in identifying a personality disorder. Next, we have the trauma and emotional history. And of course, when you look at different disorders, you find that when someone has experienced trauma within their early life, it predisposes them to having a mental illness. And that could very well be a personality disorder. So we can't take for granted someone's early life. This is why the clinical interview is so critical. And finally, as I mentioned, impulse control and reality testing. Now, critical to the clinical interview is observation. So we can have a chat with our clients about these different things, but observing the client's ability to interact with the clinician, observing how they're able to express their emotions, their thoughts, etc., can be quite telling. And the reason why it's important for a clinician, a psychiatrist, or a clinical psychologist to engage in this type of interviewing is because they are able to interpret the observations in a clinical manner and make sense of it, right? So next slide. I wanted to discuss the MMPI. The reason for this is, based on my experience, this MMPI is available within a public healthcare setting for mental illnesses. So if you are working in a public setting, chances are this tool may be available to you. And so I wanted to give you an introduction to it so that you are at least aware of what it is, even though you may never have to use it. So it consists of 567 true or false statements. It's long. It takes about 60 to 90 minutes to complete. So could you imagine someone with a literacy challenge? They may never finish because it's real long. It includes 10 scales, which ranges from hypochondriasis to social introversion. And also it includes validity scales, which is really good. So it aids in assessing the accuracy of clients' responses. So for example, one of those validity scales is called the L scale. And this aids in detecting where clients aim to present themselves in a more favorable light throughout the use of the tool. So you may find that someone wants to make a good impression, right? So they're not too truthful and they don't necessarily want to reflect the real behaviors that they are exhibiting in their day-to-day life. So they select responses that indicate that their reality may be more favorable than it actually is, right? And so the L scale is really good at picking that up. And it also, it all ties into the final score and the final outcome of the MMPI. I wanted also to make mention that there is an MMPI that is available for adolescents. I believe it starts from the age 14 to the age of 18. So it can be used in an adolescent setting as well. Next slide. All right, so why is assessment so crucial? These are the factors that we must consider. Comorbidity of personality disorders. So as mentioned previously by the study that we discussed, or that I discussed rather, more than 50% of persons that come into the psych ward or to be treated for substance use disorders have a comorbid personality disorder. And so we must consider that, and that's why we must assess for it, right? The next thing is the influence of an undiagnosed personality disorder may have on treatment outcomes. So let's say, for example, someone comes in for treatment for a substance use disorder, and we don't screen them for personality disorder, and we just go about, you know, a treatment plan as usual, doing everything that we have to do, and this individual is not adhering, or the outcome is not as you would have hoped, or the outcome is not as it would have typically been. Yes, so now we're bumping our heads thinking, well, what's really going on here? We're doing everything, crossing our T's and dotting our I's, and we're not getting the outcome that we want. The reality is an undiagnosed personality disorder could totally derail treatment, right? And I think it's pretty similar for HIV, in that if we have someone who's diagnosed with HIV and we're trying to treat them, but they have an undiagnosed personality disorder or any other mental illness for that matter, is going to derail their ability to adhere to their HIV treatments. So it has to be something that we look at. And finally, a client's presentation on a given day may not reflect the symptomology that they are experiencing. So you have someone again presenting with a substance use disorder, for example. We have to be sure that what we see in front of us is not really taken as wholesale, because there may be other influencing factors creating that presentation. So we can't just chalk it up and say, oh, well, they're drunk, they're inebriated, they're high, or whatever it may be. That's why they behave this way. When in reality, yes, they may be under the influence, but there is also a comorbid personality disorder, which will definitely help. And so we just can't take the way a client presents before us as the be-all and end-all answer. All right, so almost to the end, and I found it necessary that we discuss borderline personality disorder, because this is a pretty commonly encountered disorder, personality disorder. And I can say that for here at MRF, within the past year, I think I would have had 5 is a safe number of persons who comfortably meet the diagnosis of a borderline personality disorder. And when you take that in conjunction with the total number of referrals that I would have received, that is a significant percentage of persons, right? Within a short period of time. So that's just to show how relevant and how common this personality disorder is. According to the DSM, according to the DSM-5, this disorder comes up within about 6% of the population within a primary healthcare setting, 10% of the population within a mental health outpatient clinic, and 20% among psych inpatients, inpatients. So those percentages definitely reflect that borderline personality disorder is something to look at, right? And interestingly enough, when I first started here at MRF, I was concerned because I was like, wow, how could so many people here at this one clinic have borderline personality disorder? That's mind-blowing to me. But it's really interesting because of the type of population that we interact with in a primary healthcare setting. We have to remember that these individuals have background. So remember, we talked about those factors that influence the development of a personality disorder, and environment and surroundings are very critical to that. And also family history is a part of that as well. And so we have to consider that the population that we see are populations that may have had traumatic childhoods, they may have been exposed to trauma throughout their early life, they may have been predisposed to mental illness because a family member has a mental illness, etc. And they may have had a difficulty in also, oh, I lost my train of thought. They may have had difficulty also in, I lost it. Yes, they may have also had trauma. I'm sorry, I just lost my train of thought. But yes, so the population that we see in this primary healthcare setting is really a really special one, because we come across numerous disorders, particularly borderline personality disorder, and so we have to be vigilant about that. So the main criteria when looking at borderline personality disorder is that first blurb there, which says it is a pervasive pattern of instability of interpersonal relationships, self-image and affect, and marked impulsivity, beginning by early adulthood and present in a variety of contexts. And then we go into a long list, right? But it's really important that we remember this first part. It's a pervasive pattern of instability of interpersonal relationships, self-image and affect, marked impulsivity, and it begins in early adulthood. Yeah. So I have an acronym. You can change the slide. I have an acronym that covers the next 9 items, and the acronym basically spells out impulsive, right? So what the DSM says is that the individual doesn't have to necessarily meet each of these 9 items. They have to meet at least 5 to satisfy the criteria for borderline personality disorder. So really quickly, I'm going to run through the acronym with you, and you can look at the screen and read through while I talk about it, right? So it mentions impulsivity in 2 damaging areas, which could mean sexual impulsivity or substance use impulsivity. So that's one thing to look at. Then we have mood instability due to marked reactivity. So let's say you are the individual has a very difficult time managing their emotions. They may be in the workplace and something happens, and they have a very difficult time managing, let's say, workplace conflict, workplace interactions with a co-worker. And because of that, they have their mood instability is quite significant. Next, we have maybe paranoia or dissociation under stress. So that's the P. The U is unstable self-image. L is liable to intense relationships. So we find that relationships are a significant part of the presentation of borderline personality disorder. It's very difficult for someone with borderline personality disorder to maintain a healthy relationship. And it doesn't necessarily have to be romantic. So it includes relationships with their family, it includes co-worker relationships and friendships. All of it is quite difficult for them. Next, we have suicidal gestures. They may threaten to harm themselves or engage in self-harming behavior. Next is inappropriate anger, where individuals have so remember I mentioned mood instability and they have a difficult time managing their emotions. So a person with borderline personality may have outbursts They may have aggressive outbursts that they are unable to control. We have to pay attention to that because we can very easily identify that as another mental illness. We may look at it as possibly bipolar, maybe, but it may not necessarily be so. So we have to pay attention to all of the other symptoms that are present as well. Then we have vulnerability to abandonment, frantic efforts to avoid real or imagined abandonment. So imagine this in a relationship where this individual is making grave attempts to avoid any possibility of abandonment, whether it be real or imagined. That can put a strain on any relationship, right? And finally, we have emptiness, chronic feelings of emptiness. So the individual that you see does not necessarily have to have every single one of these 9 items. They only need 5 to meet the criteria for borderline personality disorder. Next slide. So how do we treat it? If we come across someone, so we went through what we're going to use to identify this personality disorder, which should be a standardized interview, like a clinical interview, or we could use a questionnaire like the MMPI, or we could use a projective test, right? So that's how we identify it. And if we come across something like borderline personality disorder within our primary healthcare setting, we need to know what to do to treat it. So I mentioned this in the last session, but we're going to refresh our memory on it. So treatment for a personality disorder can range from inpatient care, inclusive of medication, to talk therapy, which is the most common approach. This is dependent on the type of disorder the individual has been diagnosed with, as well as the comorbidities, if any. The most common therapeutic approaches include cognitive behavioral therapy and dialectic behavioral therapy. A combination of the two can work as well. And group therapy sessions may also be utilized to incorporate family and friends of the client. So with borderline personality disorder, because there's a huge component that affects relationships, dialectic behavioral therapy may be the first go-to. However, as treatment progresses, cognitive behavioral therapy may become useful. And so you have an integrative approach. You have the numerous therapeutic approaches at work at the same time to address this personality disorder. Now, it is important that I mention that when persons get older, you find that they no longer meet the criteria for borderline personality disorder. It's usually within early adulthood. So let's say someone within their 20s, they really have a hard time with borderline personality disorder. And as they get older, they may still have some challenges, but they may not necessarily meet the criteria entirely. They may meet the criteria for something else. So that's important to note in terms of, who we look for when we're screening, right? So when you have someone presenting in front of you and they're within their early adulthood, within their early 20s or so, it's important that we pay attention to them, regardless of what the initial diagnosis may be. It may be depression. We still have to take it the extra mile to just check and see if they meet the criteria for personality disorder. Next. So finally, we're going to review everything that I've covered. A personality disorder is defined as a persistent pattern of internal experiences and behaviors that differ significantly from the expectations of an individual's culture. Next is that awesome study that I mentioned, a personality disorder prevalence study conducted in Jamaica, found that more than half of the patients seeking treatment for mental disorders and substance abuse also have comorbid personality disorders. Therefore, it was concluded that all psychiatric and substance abuse populations should be screened for personality disorders as a part of standard assessment procedures. Next, personality disorders may be assessed or identified through structured interviews, self-rated questionnaires, and projective tests. Next is a commonly encountered personality disorder in a primary healthcare setting is borderline personality disorder. And finally, talk therapy is the most common treatment approach used for personality disorders. That brings us to the end of the presentation. Thank you all for your attention. Passing you back over to Dr. Boyce.
All right, thank you, Belinda. As usual, fantastic. Because we copious notes on this side. So again, I'm going to open it up just for a couple of minutes. If anyone has any questions or comments about anything Belinda just presented, while I'm waiting for persons, so you can raise your hand up and unmute. If you can't do that, you can always type in the chat box. So I have one question. In terms of some of those screening tools, the JPDI, the IPD, and so forth, is that something that you have to have special training to use? I mean, for all of the screening tools we use, like
PHQ-9, yeah.
Those we can use fairly easy, but those things require some special.
Absolutely, because they're quite detailed. And the scoring, so as I mentioned, the MMPI could be administered electronically, and in that way, it's scored electronically too. So you're not really involved. The clinician is not really involved in that. But if you're doing it, which most likely would happen in our public health setting, if you're giving someone a tangible paper and you have to score it, you definitely need to be trained in terms of the scoring, particularly. And this time in my research is the first time I came across the Jamaica personality tool. And it should be pretty easy to use, but of course, training in terms of how you interpret the results and all of that must occur before it's done. Yeah.
Thanks so much. So I'm not seeing any questions just yet. So what I'll do, I'll launch the poll in the meantime. You can still put your questions in the chat box or unmute or raise your hand. So we'll just sort of a quick run through to see how well our tool or polls are doing. We've started the exercise of doing some of the polls, which would have launched at the Mental Health Echo last week, just to get an idea from our learners as to how we're doing and what we might be able to do better. So to launch the poll, if you're on a device, depending on the length of the poll, you may have to scroll to the bottom, just select one or more than one depending, and click submit at the end. And we'll give it about a minute just to see how people are going. So I'm launching the poll now. So you should see two questions. First question, did you learn anything new from today's presentation? And second question, was today's didactic either too basic, too advanced, or just right? We're doing a bit of a Goldilocks for the second question. So let's run for about maybe 45 seconds a minute. All right, so far 4 people. We have how many? 6, 4, 6, 5, 5 out of 25, good. 6, right? The 6 out of 25, we'll get at least half the people responding. Again, remember, if you're on a device, you have to scroll to the bottom and click submit when you've answered those questions. All right, so far we're 8, keep going. Aim for 25%, hopefully. And by the way, the answers are confidential, so nothing you answer, we don't know who's answered what at the end of the poll. So you can feel free to answer any way you choose. All right, 54 seconds. Okay, let's run for just a few more. Okay. I will end the poll here. All right. So I just put up the results. So far, it's all the persons who answered, 100% of you said that you did learn something and the level was just about appropriate. So again, thank you for that input. We will make note of that to help guide us going forward as to how we structure didactics in the future. So stop sharing here. Again, thank you for the participation, and we'll move on to the clinical case today.